Welcome to Uniquely Spoken Podcast, where transparency sparks transformation. Are you ready to dive into conversations that will spark ideas and inspire action? This is a podcast that refuses to accept the status quo. I am Juanita, the founder of Uniquely Spoken LLC. I started this podcast to ignite change in healthcare, starting with long-term care settings. It is time to transform nursing homes and rehabilitation centers, assisted living and memory care communities to all become premier long-term care settings nationwide. It is time for all long-term care settings to receive a 5-star quality and customer service rating. It starts now, and it starts with me. It starts with you, and you. And the time is now. Thank you for joining us for episode 4, Medication Management, Missed Doses and Nurses' Challenges Related to System Failures. Medication management is one of the most critical responsibilities in long-term care, whether a resident lives in a skilled nursing facility or an assisted living community. Although skilled nursing facilities operate under federal regulations and assisted living communities operate under state regulations, the medication-related vulnerabilities that nurses and medication aides are encountering are strikingly similar. Missed doses, delayed medications, and documentation discrepancies do not belong to one setting. They follow residents across levels of care. And that's because the risks are not often created by the building, the nurse, or a medication aide. They're created by the systems that support medication administration. Today's episode is about what happens when those systems fail and why both skilled nursing facilities and assisted living communities are experiencing the same outcomes even under different regulations. Let's talk about pre-preparing medications, sometimes called pre-pouring. In episode 2, we talked about ABT Associates, a global research company who completed a comprehensive staffing study at 31 long-term care settings. In their study, it was reported that nurses prepared medications in advance of administration, batch prepared medications for multiple residents, altered the timing or sequencing of medication administration, and used workarounds when expected workflows did not fit staffing realities. While pre-pouring medications was to best manage time constraints. The practice of pre-preparing medications exists in both skilled nursing and assisted livings, often framed as a compliance issue or a shortcut. But research and real-world nursing experience tells a different story. Pre-preparing medications emerges under the same pressures in both settings. High resident-to-staff ratios, frequent interruptions, medication schedules that don't align with staffing realities. In skilled nursing facilities, this pressure comes from acuity and volume. In assisted living, it often comes from fewer licensed staff, looser staffing requirements, and increasing resident complexity. The regulations differ, but the workaround is the same. Pre-preparing medications is not a reckless act. It's a symptom of time compression. And when systems require real-time administration without providing protected time to do it safely, risk increases regardless of settings, putting residents' lives at risk, and nurses and medication aides licenses and certifications at risk. You have to know that they're doing it because this is the only way they are able to adhere to time constraints and manage other important, if not critical, responsibilities. Another major contributor to missed doses that doesn't happen at the bedside at all, but due to system support. Pharmacy delays occur if a new medication is prescribed at a skilled nursing facility that do not have that drug in their emergency backup, or for an assisted living that does not have an emergency medication backup. And it's a Friday, and the pharmacy does not deliver on weekends or have a local pharmacy that can deliver the medication to ensure the medication delays do not exist. Pharmacies are encountering delays because prescriber clarifications and refill orders are not being handled timely. Oftentimes, physician offices are saying they did not receive the fax or the communication, and there are substantial delays with getting medication orders clarified or refilled. And insurance authorization barriers also affect both skilled nursing facilities and assisted living communities because they both rely heavily on external pharmacies and providers. When medications are delayed, the nurse or the medication aide may have to follow up repeatedly. Documentation reflects a missed or delayed dose. The resident still doesn't receive the medication and their health and well-being is being compromised. In skilled nursing facilities, this is often tracked as a medication omission. In assisted living communities, it is still framed as a medication omission. But the root cause is the same: upstream system delays that staff cannot control. Different oversight, different regulators, same failure point. And oftentimes when a medication is missing, the nurse or the medication aide is stopping midpoint of medication preparation and administration to determine where the medication is. Oftentimes out of fear of a missed dose and having to document a missed dose and being held accountable for documenting a missed dose. Also, with the medication administration record, reconciliation errors occur. Medication reconciliation is one of the most under-recognized risk points in long-term care. Transitions from hospital to skilled nursing facilities, from assisted living to skilled nursing facilities, from hospital to assisted livings. Discrepancies are existing. Medications are being omitted. There are duplications occurring, incorrect doses or frequencies. Once those errors enter the medication administration record, they follow the resident until someone identifies the error. And how long that can take can depend on what nurse or medication aide identifies the error. In skilled nursing facilities, reconciliation is expected but often under-resourced. In assisted livings, reconciliation is expected but often under-resourced. Reconciliation responsibilities may be less clearly defined, and the consequences are no less serious. Remember, we said skilled nursing facilities and assisted livings share a similar vulnerability. In both settings, staff may administer medications exactly as documented, even when the documentation itself is wrong. Nurses and medication aides are being forced oftentimes to rush with medication administration based on staffing ratios. So the likelihood of them capturing the error is minimized. You see, the mar becomes the hazard, not the safeguard. And if a nurse is already overwhelmed and faced with one or two admissions, and those residents have polypharmacy or have several medications that need clarified, then the errors are more likely to occur. Again, the medication administration record becomes the hazard opposed to the safeguard it is supposed to provide. So this is one of the reasons why Uniquely Spoken Podcast is asking nationwide, what long-term care setting have a 5-star quality and customer service satisfaction? What systems are working in your long-term care setting? Help us to redefine regulations that all long-term care settings can receive a 5-star quality and customer service satisfaction. Is it your staffing ratios? Are you staffing based on acuity? What system is working when it comes to medication management in your long-term care setting that you can share so that we can put together a proposal that will justify changing regulations on a federal and state level where we can make a difference in the lives of individuals who are relying on healthcare workers to meet their everyday needs. The time for change is now. The medication risk chain. When we map the medication risk chain, the pattern holds true across both settings. Upstream delays, flawed reconciliations, time compression, workarounds like pre-preparing medications, missed doses, and adverse outcomes. Skilled nursing facilities experience this under federal scrutiny. Assisted living communities experience it under state scrutiny. But the resident experience and the risk is the same. Different regulators do not eliminate the shared responsibilities. As we close today's conversation, remember this: real change in long-term care doesn't start with perfection. It starts with honest awareness. If this episode sparked reflection, challenged assumptions, or mirrored what your daily journey is, don't let it end here. Take the next step. Follow the podcast so you don't miss upcoming conversations or becoming a guest. Share this episode with someone who needs to hear it. And continue the dialogue beyond the bedside and beyond the policy manual. Transparency creates momentum, and momentum creates transformation. This is Empowering Healthcare, and the work will continue. Thank you again for joining us. We broadcast every Tuesday, 5:30 a.m., 8:30 a.m., 3:30 p.m., 6 o'clock p.m., Eastern Standard Time to allow accommodations for all time zones. Now, don't forget to tune in next week. This will be an interesting episode. Thank you for joining us on Uniquely Spoken LLC podcast. Please subscribe on Spotify, Apple Podcasts, or wherever you listen. Remember to connect with us. Follow, comment, subscribe, share, be a guest. Visit us at uniquelyspoken.com/podcast. That's UNIQUELLESPOKENLC.com/podcast. Or if you are a viewer, scan our QR code. Please remember to stay informed, stay empowered, and keep the conversation going. We love hearing from you, and we'll see you next week.